Good. Thank you. Thank you, David. And I should probably just point out that on my badge it says astronomer because I was watching stars until midnight last night. I've got three things I was going to mention in response to David's thoughts and observations. I'm a geriatrician. I mostly deal with the firefighting end of the business in my everyday activity, but I'm also a clinical researcher in my other half of my job. One of the things I think that we need to do is to think much more carefully about exactly what we're trying to achieve in healthcare, especially with older people. And I think for many older people, we've got the focus of the outcomes rather wrong. And this has really sort of led to the ridiculous situation that you have with the QOF targets, which are mostly wholly inappropriate for older people, don't reflect their needs, don't reflect what older people themselves demand of healthcare. So I think one of the radical things that we can do is to rethink the kind of outcomes that we are actually trying to aim for. Older people themselves tell us that it's function and quality of life. They've told us that for the last 20 or 30 years. We're not measuring that. If we're not measuring it, what hope have we actually got of achieving those outcomes for older people? That then leads on to rethinking the types of interventions that we put into place. And unfortunately, the interventions that we put into place, I think, too often do harm rather than good, or at least at the best do questionable good. And typical of this is the thinking that still leads us to look at older people in terms of disease silos. Diabetes being the classical example here, where the only thing that diabetologists are interested in is how high your blood sugar is. It doesn't matter how high your blood sugar is. As long as it's below about 20, or if an older person, it's really not important. What's important to older people is not going too low so that they don't black out and so their brain doesn't stop working. And what's also important is not having to take all of those horrible pills and those injections. So if we can think more carefully about the interventions that we use, we might start making some progress. What I would like to see, and I think as a public health community we're in a fantastic place to drive this forward, is a focus on pleiotropic interventions. We have pleiotropic interventions most notably in terms of exercise already, but we need to be rethinking our whole suite of interventions so that they tackle multiple problems that older people suffer from. Gone are the days when we can afford to have half a dozen different interventions focused on each single disease that older people have. Older people come as a package. They have multiple problems, they have multiple diseases, and we need to find ways to tackle those multiple diseases with a relatively small number of interventions. And that, I think, is the key to making sure that we maximize benefit whilst minimizing risk and cost. The second thing that I wanted to mention then is evidence. I'm an academic. My job is to generate evidence for older people, and unfortunately we are still doing extremely badly in that. We're not helped by the fact that every time we try and generate evidence, policymakers turn around and decide that something else is important. They change the whole system that we're working in. But without that evidence, we are going to waste an awful lot of money and we're going to do an awful lot of harm. And we need to redouble our efforts to generate that evidence. Now, I would like that evidence to be based on randomized controlled trials, but I'm realistic enough to know that in a complex environment such as healthcare for older people, that's not going to happen in a lot of cases. But we at least need to build our ability to develop robust ways of assessing interventions and do it rapidly and do it so it's embedded in everything that we do. And if we can do that, I think we're in a much better position to do the third thing that we need to do, which is to disinvest. We are notoriously bad at disinvesting in any kind of sphere of public activity, but especially healthcare for older people. People will not let go. My colleagues, I have to say, are some of the worst that I have ever come across for that. They are clinging on to outmoded ways of working that really should have been thrown out 30 years ago. They are continuing to deliver healthcare that we know is actively harmful, and they are also continuing to put lots of time and energy into doing things that at best are unproven and at worst may actually be doing damage as well. I can give lots of examples if you want to come up and talk about that later. And if we can disinvest, then we may be able to reinvest and actually start doing something that's some good. I could probably stop doing 90% of what I do in my clinical work and nobody would actually notice the difference, because most of what I do is either unproven or useless. So why not stop doing that and start spending that time, effort and energy, the human capital really, on doing something that might be useful. And my final thing that I wish to just say is, and really in response to what David said about workforce development, is I am convinced as I get older that doctors are not the answer. And so I hereby vote myself out of existence and leave my colleagues to give their comments as well.
Brilliant. Thank you very much. Thank you indeed. So you may want to say what's on your badge, or you may want to say something you think people need to know about you before you crack off, but 5 minutes then.
Okay, thank you. My name is Glenda Watt. I work for the City of Edinburgh Council. I think I'll speak from the point of view as an employee of the council, but also an older person as well, and also as a person who's connected to Age Scotland. Over the last 13 years, I've been working to implement a strategy called A City for All Ages, which is about older people. And it was an attempt 13 years ago to recognise older people not as recipients of health and social care, but as contributors to society. So over these years, I've worked with large groups of people in Edinburgh, but also now at a national level. And so older people have, in a way, celebrated the fact that they are living longer, and that there are many older people who are not going off to the doctor, not in hospital, but they're part of the community, they're part of the economy, and they're acting as volunteers or they're carers. They're caring for other people, either in employment or as family carers. And of course, this should be celebrated and this should be promoted. One of the things that an older person had said to us when we started this work was that they wanted to have relevant information about what was out there. They wanted information to know how to keep active, to keep well, and to keep up with pensions and general information. So we set about pulling together information and producing a booklet. It's called Get Up and Go, and that's been on the go for 13 years. It's been designed by older people, and it's been critiqued by older people as well. I think I would agree with some of the things that David has said here, and about some of the statistics that have come forward, but it's not the whole picture. And of course, the whole picture must involve older people and the voice of older people themselves and their experience of life, what they're experiencing now, but what they've experienced in the past. Many older people have been telling us that they have a fear that they're losing the services, but they're not quite in tune with the policies about having to look after themselves in the best way that they can. Some people need information and help to do this. I also work with a group of people to organise the Scottish Older People's Assembly. We've had an assembly each year since 2009, and the next one is planned for the 5th of December in the Edinburgh International Conference Centre. This will be an opportunity for older people to come together to have a discussion about the impact of welfare reform on older people and active citizenship. So I hope that we will be able to pull together the voices and experience of many older people from across Scotland, and we'll be able to put that voice to the Scottish Government and the Westminster Government about their experiences.
Brilliant. Thank you very much indeed. And last but not least, Lisa.
Hi there, and I'm Lisa Cohen, and I'm in the evaluation team at Health Scotland, and I am also a grandma, so congratulations to you. I know how great it feels. The work that I've been involved with over the last year has been to help and facilitate the development of an outcomes framework for older people, and actually the comments you were making are extremely relevant, because it was all about how can we actually really make a difference to older people's lives. So what do we want to achieve? And what are we actually doing just now, in other words, and then what needs to change? So what we've been doing is putting together the strategic vision, if you like, of the main pathways to achieving the high-level outcomes, which are most important to older people. And I think that's the important bit about our work, is that we've started with what we felt was the needs and the wants from the older people's perspective, not from where the services or the experts felt they should be. So it is the points that have already been made. It's very much about the quality of life, you know, physical function, mental well-being. It's very much about having an age-friendly physical and social environment. It's about being valued and connected to society. And it's about being consulted and involved in any decisions that affect an older person's life. And the final one is very much about financial security, and in terms of having, they can live a life that they want to live. Now, it's quite interesting when we've been doing this work that, the Scottish Government major outcome is very much about the drive for independence, about people living an independent life. Now, that is what many older people want, but the reality is it's with constraints. So as we talked about the housing stock, we talked about somebody living in their own home. There's a drive to keep people in their own home, but that's all very well if you've got a social connectedness and a social environment that supports that. So if you're living in isolation and you don't see somebody from week to week, then are you better off being somewhere else? What we've also found about this work is there's a huge issue about shifting the balance of care. We started off this work and it was very much about reshaping care of older people, and it was looking at that strategy specifically. But we recognised that once we had highlighted these outcomes, that actually it's a driver for older people in general. It's a driver for the 30, 40 government policies that pull into older people's health. So it's become much bigger than we originally thought. What I've been finding, and I think what's the really interesting thing, is the kind of mismatch between government policy, the big policy, and what's actually happening on the ground. And I think you've alluded to some of the key points there in terms of, and the examples that spring to mind for me are, for example, the driver for heat targets. So it's about reducing emergency admissions to hospital. It's about getting people out of hospital as fast as you can. So from the medical perspective, it's almost about fix them and get them back out there. But the reality is for older people, to get them back into the community, we've got to have the infrastructure in shape to actually support them. And I think we're a while away from doing that. And one of the big issues that gets raised just now, and one that keeps coming up in the work that I've been doing, is the issue about 15-minute home care visits, which is, actually doesn't actually meet older people's needs. It doesn't meet, whose needs does it meet? It's actually a real frustration and difficulty for the service providers, because they are being tugged in every direction. They're not being supported. They're not being able to do their job properly. And actually, does that really meet people's needs? So our driver is very much about what do older people need? What do they want? What's their values? And taking it from there. I think just one point, last point I'd like to make, and I'll be quiet, is the point that you made, John, about the healthcare costs rise very close to death, but the reality is that with the health inequalities, and then you alluded to, life expectancy and when poorer health actually fits in, but for the most deprived communities, you're talking about it maybe starting 15, 16, 17, 20 years before death. And actually that's where the focus starts to shift on healthcare and a lot of extra costs. So for us, a lot of it is about prevention and trying to pull the prevention agenda together. I can say lots more, but I'm sure you want to.
Okay, brilliant. Thank you very much indeed. So three really interesting perspectives on the topic. David, is there anything in that you want to particularly come back on? You've not got very long, but if you had one or two comments, that would be. Sorry, can you press the grey button on your microphone?
Just two things. One is that it would be great to try to figure out a way whereby the world wasn't driven by top-down objectives and did come from the bottom up to some extent. And how do we make that consistent with the resources that overall are available? That's a key issue, but it does seem to me to be important to try to move things much more towards a bottom-up approaches. The other is in terms of evidence. I should say I gave a talk yesterday that we are trying to do something in this area. We are trying to set up Scottish Longitudinal Survey of Ageing, and I won't bore you with the details of how that's being done, but I would suggest that if you want to see some good evidence across the board in relation to aging, you look at either the Health and Retirement Survey in the US or the English Longitudinal Survey of Aging, which has been going for some time. and which has generated huge amounts of useful research, both in health and in the more general social sphere.
Brilliant. Thank you very much.